Well, we'll go ahead and get started. I'm Sharon Rounds. I'm the PI for Advanced Rhode Island CTR, and it's my great pleasure this afternoon to welcome Dr. Jody Rich, who is going to be our distinguished clinical translational science research seminar giver today. And Jody will be talking about the opioid and overdose crisis in Rhode Island and beyond, provide us an update on this extremely important topic. By way of introduction, Dr. Rich is a professor of medicine at the Warren Alpert Medical School and also has a professor of epidemiology at the Brown School of Public Health. He's a attending physician at the Miriam and Rhode Island hospitals. He's been working for over 2 decades in the area of infectious disease and addiction, and has served in the process, has served as a consultant to the Rhode Island Department of Corrections, where he provides clinical care and has for the last 30 years. Doesn't seem possible. And he is a national and international figure, recognized for his expertise in this area, an elected member of the National Academy of Medicine, and a prolific author, and also not infrequently quoted in the New York Times and other national publications. So, Jody, it's a real pleasure to have you here with us today to tell us about your important work. And I would say to the audience, feel free to put questions into the chat. We'll be monitoring it. Some questions we may hold for the end, others will interrupt Dr. Rich, and he can deal with them as they come along, but just please put them in the chat. And again, thank you, Jody.
Thank you so much, Sharon, and thanks to Advanced CTR and Advanced RI-CTR and all of you. I'm honored. So I know I'm committing a little bit of heresy here by not having any slides, but I'll try to make up for visual learners by showing some pantomiming some slides. So here's slide number 1, which is a graph of the overdose deaths in Rhode Island and in the U.S. They have gone up substantially. It's also a graph of incarceration in the United States. It actually, incarceration's gone up, and then in the last little period of time, it's kind of turned a little bit down, and people have said, oh, well, the epidemic is over. Now we don't need to worry about all this incarceration. But of course, we are up here, and the rest of the world is down here. I guess that's slide 1A. So those of you who read the little blurb about this talk will know that at the peak of the AIDS epidemic, 50,000 Americans died in a single year. And I was there at the time in the front lines, and that was a horrible tragedy, a real Holocaust. But in the last 2 years that we've had reported data, and probably in 2023 as well, overdose deaths have more than doubled that. There have been more than 100,000 Americans have died of an overdose in each of those years. So almost 3 years running now, and no real end in sight. So this is an epidemic that's beyond the AIDS epidemic. It's beyond the amount of people killed in war, amount of Americans killed in wars, and it's only surpassed by two tragedies in the last century: the COVID pandemic and the 1918-19 flu pandemic. So this is a big one, and I, a recent study just came out in JAMA, RAND study, showed that 42% of US adults knew someone who had died of an overdose. 42%. And of those people that knew someone, the average number of people that they knew was 2.9. So almost, 42% know about 3 people who have died, know them. 13% of Americans that have lost someone in their life felt that disrupted their life. It wasn't just, some guy down the street died. This was something that impacted their life. And that comes out to 40 million adults, not mentioning the children who are deeply impacted by sudden loss of life. 4% of Americans have been devastated by the death of someone. In Rhode Island, it's hard to, and Rhode Island has been impacted more heavily than most states, and it's hard to find a family that hasn't been impacted in some way. It's a coworker's child. So this is a big deal. If you take nothing else away from this talk, a fundamental problem here is the tremendous stigma associated with illicit drug use, and particularly opioid use. That has held us back from doing what we need to do, and continues to, in so many ways. All right, so I'm going to talk about 3 things. First, I'm going to talk a little bit about my background, how I got here. Then I'm going to go into spending a fair amount of time about the disease itself, how you diagnose it, what the risk factors are, what it's like to have it, and then how to treat it. And it's very important that we understand this, because most people don't really understand it at the level to make informed, to understand what needs to be done about it, and what we can do about it. And then third, I'm going to talk about the current epidemic, where we are, and that this has been a rapidly twisting, turning, evolving epidemic. We are now in the 4th wave, which I'll get into. All right. So, any questions so far? So Sharon's right. I came to Brown 30 years ago. Yeah. 30 years ago, 1994. The HIV/AIDS epidemic was in full swing. We did not have effective treatments. We had treatments, but they were not yet effective. And it was a Holocaust. It was really awful. People were dying left and right. And Rhode Island, oddly enough, was one of only 4 states with more than half of the AIDS cases were related to injection drug use. So we were a predominantly injection drug use epidemic in the 1990s. And I joined this wonderful team here, and our mission was to really find people, provide care for them, and do the best we can, and with the hope that this would soon become a chronic disease that we could manage, as opposed to the deadly disease as it was. So with doing that, doing outreach in the community and at the Department of Corrections, I learned about addiction, and I met a lot of patients who had addiction. I learned a lot more. I mean, I grew up a child in the 60s, and I decided to quit smoking pot because I didn't like what it was doing to my brain. It was making my brain a little fuzzy, and that was when I was in the 8th grade. It was a different time in the 60s and 70s. Brian Stevenson is one of the few people whose lecture I've heard several times, and each time it really sticks with me. And so if you ever get a chance to hear him speak, he wrote a book called Just Mercy. It was made into a fancy movie. And one of his main messages is, if you want to work with somebody, help somebody, you have to get proximate. You have to get close to them. And so I was getting proximate to people, both in the community and at the Department of Corrections. Department of Corrections HIV program had been started by Chuck Carpenter and Tim Flanagan and Susan Kuhuvin got in there early, and I just joined that team. And I've been locked up just about every week since then. But I've also been released just about every week as well. By getting proximate and talking to patients, I kind of, I didn't understand why so much injection drug use HIV existed. And it turns out the syringes were illegal. 5-year felony offense for possession of a single syringe. I had a patient who was arrested with a dozen syringes in his pocket. The judge wagged his finger at him and said, "I could send you to jail for 60 years. Life sentence. Just syringes, no drugs." At the time, heroin was illegal to possess as well, with a 3-year maximum penalty. So anyhow, by syringes being outlawed meant that in the sort of cat and mouse game between the people who are using drugs and the law enforcement, the focus became not so much on the behavior, but on the syringe. Because if you get someone with a syringe, you've got them. You catch them with a bag of substance, you have to send that to the lab. They have to analyze it. You have to wait for the report. You gotta, when you got them a syringe, it's a done deal. You got them, and it's a 5-year. It's more than, and you can squeeze them, and then go up the feeding chain. Which is so people quickly learned that you shouldn't carry a syringe with you because you're gonna get caught and you're gonna get jammed up. So people would not use a syringe and not carry a syringe with them. They'd go someplace to buy their drug. There would be a syringe there. They'd take the syringe, they'd use the syringe, and then they'd leave it there. And then next person would come and do the same thing. You almost couldn't design a better way to transmit bloodborne pathogens in a population. And that's what it showed. Now, and go back to slide 1, that's what happened with injection drug use related HIV in the state. We did some advocacy at the State House, and one of the things we said is that, this is slide 2, injection drug use related HIV is like this, slide 1, and if you pass this bill to legalize syringes, it will come right down. And that's slide 2. So they listened, they passed the bill, syringes became legal, and without the work of Jeff Bratberg and others, but Jeff really leading the charge, training every single pharmacist in the state that giving someone a syringe is not telling them to go use drugs, because they're going to use drugs regardless of what you tell them. And they're going to inject it regardless of whether you give them a syringe or not. They're just going to use a sterile syringe versus a contaminated syringe and pass it on. So you're actually preventing spread of disease by giving someone a sterile syringe. So that message got out, and the slide was actually true. That's exactly what happened. Injection drug use related HIV disappeared, and only to rear its head many decades later with the opioid crisis. Okay, so going into the Department of Corrections, found many people with HIV, and it was a strange environment. It's not a medical setting per se. It's not. It needs to have medical services, but it's not. It's not that. And so that's kind of interesting. But I got a close look up at the carnage of the war on drugs, or the war on people who use drugs, more likely. And also people with mental illness, because when somebody got their mental illness and or their addiction addressed successfully and released back to the community, if they were doing okay, they would come and see me at the Miriam to help get their HIV taken care of. If they didn't, they would come back to intake at the Department of Corrections, and I would see them there. So it's direct court. So these are not bad people that have, they're incorrigible, they're just getting locked up. No, they have a disease. They either have mental illness or addiction or both. and that's what we should be focusing on. So we developed model programs and described it to treat, diagnose, and link to care people with HIV. And then we thought, well, why not do that same thing for addiction? There's plenty of addiction out here, and opioid use disorder was fairly common then, and we had methadone at the time. So we said, great, let's do that. And we ran into a brick wall. Just no, we don't do that here. No, there's no evidence to do that. So then I spent about a decade writing grants and randomizing hundreds of patients and publishing in top journals evidence that actually this disease can be treated in a correctional setting. In fact, there's a lot of reasons to do that. And I naively thought that the evidence would, of course, lead to policy change, and of course it didn't. It was necessary but not sufficient. You need to kind of roll up your sleeves and start getting into the policy weeds with the policymakers. And we were able to successfully get treatment eventually in Rhode Island for people with opioid use disorder. And after we set it up, we monitored people released from incarceration, and there was a 61% drop in overdose deaths in people coming out of the Department of Corrections that year. So that was very helpful in terms of changing the tide. And the tide really is spreading across the nation now. Now, a decade ago, I lost my nephew. He was 23 years old. He was living in a different state, and he got hooked on opioids, was prescribed, and then transitioned to illicit, and then overdosed and died. He was an only child. It was just a tragedy, a terrible tragedy. And I had, of course, lost many patients to overdose over the decades, but it's different if it's someone you bounced on your knee. So that really hit me hard and made me kind of reevaluate. And of course, I'd been doing work in corrections, work in HIV and other infectious diseases, hepatitis, and and addiction. And I realized that there's too much fun to be had, really. But I felt that like was over 50 at that point, and was thinking I got a limited time left on this planet, and if I kind of focused my efforts on one thing and really throw my shoulder into it, I might make some headway. So I made a conscious decision to focus on opioids and overdose, and that led to the wonderful COBRI on opioids and overdose. And I would certainly like to thank Tracy Green, my partner in crime with the COBRI, and so much else, who's and the whole team at the COBRI. Really an inspiring group and a lot of fun. And I encourage you all to kind of check us out and get involved and come on in. The water is warm. It's an interesting journey. Okay, so that's enough about me. Going to spend a chunk of time on the disease opioid use disorder, we call it now, opioid addiction. If you call someone a drug addict or a drug user, it's really stigmatizing. And this is the population that I mentioned. This is the stigma is the main problem, and really a main obstacle to getting to where we need to get to. So I would try and use person-first language. Is very important. Now, the basic definition of addiction is ongoing use despite adverse consequences. It's not in your best interest to keep using, but you do keep using. Now, there's two things that distinguish opioids from most other addictive substances, physiologic characteristics. The first is tolerance. If you use a certain amount, if you use on a daily basis, you will develop tolerance. And the the more you use, the more you need to use. And so that's the kind of, you know, the same is true for alcohol, but not to the same degree. There's usually a leveling off of alcohol. I mean, everybody has an uncle so-and-so who can drink everybody under the table. He's got a wooden leg that he puts all the alcohol into or something. But with opioids, it's pretty consistently goes up, and almost the sky's the limit. That people with unlimited resources, you know, rock stars and the like, they just keep using more and more and more and more, and they can tolerate stuff that would kill a horse, but they you know, tremendous tolerance. Second physiologic property is the withdrawal phenomena, and this is responsible for much of the destruction of this disease. If you use opioids on a regular basis to the point where you develop tolerance, and that can be days to weeks on a regular daily use, and you stop, if you stop abruptly, you will start to develop withdrawal symptoms. And you know, withdrawal, it often starts with a kind of like a little feeling, a little itchy, a little uncomfortable. You start, you know, sniffling, and you just start to feel a little achy all over, and fidgety. You can't quite sit still, and then your belly starts aching, and then you kind of doubled over, and then you know, you get the sweats, and you start having diarrhea. You start feeling nauseous. You start vomiting. This is as it gets more severe. And you know, imagine the worst flu you ever had and the worst stomach bug you ever had. Put them together and multiply it by 50 or 100. That's what people describe it as. And you should, if you haven't already, if you know someone who's been through this or meet someone, you should ask them to describe what it's like. But it's horrible, and people feel that they're dying. You know, I had one patient said, you know, I know if I'm going to go into withdrawal, I'll take a bunch of sleeping pills and I'll sleep through the first 24 hours. But then I'm awake and I'm sitting there minute by minute. The clock is just going tick, 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 and I just feel awful. I just feel, you know, worse and worse and worse. Now, when people were using heroin, that would go up and up and up and peak at about 3 or 4 days, and then it would come down. I think that might be slide 2. Anyhow, and then by the end of a week, you feel like you're a, you know, wrung out dish rag, but you're no longer in withdrawal all the time, and you're done. Now, so I like to simplify this from my own understanding to kind of think about our, you know, we have our cerebral cortex, which kind of distinguishes us as a species, and it's our modern brain. And then we have this primitive reptilian brain in the back. And this primitive brain is hardwired for survival. So one example, if you know, I'm in charge of myself, right? I'm the boss. So tell my arm to go up, it goes up. Tell it go down, it goes down. Tell myself to hold my breath. I hold my breath. I'm the boss. I'm in charge. I'm steering the bus. But after a couple of minutes, my primitive brain is going to say, okay, you had your fun. Now get out of the driver's seat. We're taking over, and you're going to breathe. And I don't care if you're in a, you know, if you're James Bond in the room when the poison gas comes in, or if you're underwater, it's impossible to hold your breath to the point where you will die. So that's just basic survival that's hardwired into all of us. So if somebody feels like they are going to die, they will do the most god-awful, desperate things. And it turns out Homo sapiens is a pretty crafty creature, and they do all kinds of crafty things. So it's not that you're doing this on a day-to-day basis. So, you know, somebody's using, they start to use, they get this feeling of euphoria. And here's So here's a baseline. That's normal. That's how you feel. You take a dose and you feel this pleasurable sense or relief of pain, and then it wears off and you come back down to your baseline. And then you take another dose and do that. And that goes on for a while. But then as you develop tolerance, you don't go up quite as much because you have tolerance at the same dose. But then you start, as it wears off, you start to go down below your normal pleasure scale. And then you start to go into withdrawal. And then, you get another dose. And then you come back up. But eventually your tolerance goes up. And then your dose goes up. And your tolerance goes up. And your dose goes up. It's a vicious cycle. So then eventually you're down here. And you get enough dose to just get you up to the kind of normal, but then it starts to wear off, and then you start going down again, and you need to get another dose. So what you're doing that whole time is operant conditioning. You are changing the pathways in your brain so that you associate feeling poorly with the need to get an opiate, because I described somebody 3 days of feeling misery. That whole time you're going through withdrawal, you just get a little fingernail full of an opiate into your system, it's all going to melt away and you're just going to feel normal. And in fact, patients say that all the time, say, Doc, I don't even get high anymore. I just want to feel normal. And if you think about a street scene, there's somebody who has an alcohol use disorder and they've got a brown paper bag with a bottle in it, and they're sipping away and sitting on the corner and having fun. And the person with stimulant use is kind of tweaking away and fidgeting and picking their hair and going. Person with an opioid use disorder, they are up and they're running and they're going back and forth because they've got to hustle, because the clock is running, and as soon as their opiate runs out, they've got to get a dose or else they're going to go through this misery.
Jody, this would be a good point to ask a question that came up in the chat. Since opioids work on the pain receptor, is there a feeling of pain during withdrawal?
Absolutely. The pain, it is total body pain. And it is a pain that it is torture to have someone go through that. And it's traumatizing. So absolutely. And, I heard this quote. Some guy said, on a pleasure scale, the best orgasm I ever had was a 12. And when I saw my son being born, it was a 14. And when I get a good hit of dope, I'm at a 73. And I like, oh my God, how are we gonna compete with this? Like, this is the pleasure is there and the pain is there. It's really dramatic. Okay, so now I talked about tolerance, and if you take medicines on a daily basis, and we've all had grandmothers or somebody who's fallen and broken their hip and got a week's worth of opiates or 2 weeks, and they took the opiates and they didn't develop, they didn't turn into a raving lunatic doing everything they can to get drug. And that's because most people who take an opiate, even to the point of tolerance and withdrawal, do not develop opioid use disorder. Again, ongoing use despite adverse consequences. So there are some people that are more at risk for it. And the number one risk factor is genetic. That's somewhere between, 40 and 90% of it is genetic. Sorry, kid, you screwed up. You picked the wrong grandparents. That's a joke. But there is, now, it's not like we haven't been looking. Nobody's found the gene. So it probably means there isn't a gene. There's probably a family of genes, and it probably has to do with metabolism and different things on the receptor, and maybe other things as well. And what I've noticed clinically is that many people develop there's a wide variety in terms of response to treatment and ability to get off of treatment, off of medication altogether. So the second risk factor beyond genetics is situational. So that could be peer pressure, that you're just in the wrong crowd. But the other one is trauma. Trauma is so ubiquitous. So imagine you're a young person and you get sexually molested as a child, and you try and tell someone about it, and the first thing you hear is, no, he would never do that. I don't believe you. You're lying. The second thing you says, and even if he did do it, that's you. It was probably your fault because you'd caused him to do that. And then the third thing you hear is, oh, by the way, we don't talk about that. And so you kind of come into your adulthood carrying this psychological burden that's occupying your entire, waking and sleeping life. And then somehow you get into an opioid and that just melts away. It's not like it's not there. It's there. It happened. It's over there. I can deal with it. Now I can get on with my life. And how wonderful that is. That is such a great feeling that trauma doesn't have to control me. And then the opiate wears off and it comes crushing back down on you. So who wouldn't want to go back to that, that feeling that you just got? Now, of course, you can have all the trauma in the world and the worst genetics, and if you never get exposed to an opioid, you're never going to get into that trouble. So that's what really kicked off this crisis, is we ramped up the opioid prescribing. And for those of you who are auditory and visual learners, the show Dope Sick on Hulu is really tells a remarkable story about the beginning of this crisis with the prescribing. People who are desperate will resort to whatever they can do to pay for it. So they often get involved with stealing, in the sex trade, in the drug trade, and if you have a supplier and you can get somebody else hooked and then you become their supplier, then you can take a little bit of theirs and then your life is a little bit easier. So it can act like a contagious disease. If you can convince other people to get hooked, then your life is somewhat easier. And people do things that they would not ever do or even consider doing. All right. Okay, we've talked about tolerance and going through withdrawal and then getting beyond it. And then you'd say, well, that's good. But then I also mentioned that the brain has changed. One example of that is at the Department of Corrections, there was a patient of mine, and he was sitting around a card table with a bunch of guys. And they're just sitting there, playing cards and chatting about, life. And then one of them started telling old war stories about using. It says, oh man, once I got so high, it was great. And then the other one said, oh yeah, I did something like that. And they're talking about it. Now, they'd all been incarcerated, had their lives turned upside down, lost their freedom because of this disease. They paid quite a price and continued paying a price because of their use. And they'd all been locked up for long enough to not need to be beyond the withdrawal, and so they were just sort of normal. And you look around the table, and pretty soon they're all sort of fidgeting. They're all kind of shifting. Their noses are running. They got goosebumps. They are experiencing opioid withdrawal symptoms, just because the images that they were talking about tickled memories and prior experiences. And I can guarantee you, if I had put a piece of, an opiate on the table, they all would have gone for it, despite adverse consequences. So, holding someone locked up away from opiates is not the answer. It's not going to work. 90% of people going through overdose are going to relapse. All right. So what do we do about it? We have 3 medications that are approved to treat this, and that's a critical point. We also have 80% of people with this disease, and there's about 2.5 million people in the country with it. 80% are never get access to medications for opioid use disorder. The 3 medications are methadone, buprenorphine, and depot naltrexone. Naltrexone is a blocker at the receptor. It is has the poorest evidence in terms of long-term efficacy at reducing overdose deaths. Methadone is a pure agonist. It turns on, it binds the receptor and turns it on. So it acts like any other opioid, except that it has a very long half-life. So it stays in your system for a long time. And the third one is buprenorphine, which is a mixed agonist and antagonist. Binds on the receptor, turns it on partly, but has a bit of a ceiling effect, so that the more you take, you're not going to get higher. You're not going to turn on the receptor anymore. But at the low doses, it'll work just like any other opioid, and it's proving to be very helpful in chronic pain. But so they all bind on the receptor. They have different mechanisms, but they work in terms of this disease by blocking the ability for another opiate to get onto the receptor, because the receptor is bound by either of these 3 that are blocking any other, and certainly worked very well with heroin. With fentanyl, it's less so, and because fentanyl is that much more powerful, 50 times more powerful than heroin. Okay. Now, when I meet someone and they have this disease, I don't tell them, I tell them, what you really need to treat this disease, you need to get into recovery. And recovery is 4 things. It's working, it's not like you climb the mountaintop and you put the flag in and you say, we're done. It's more about a way of living. It's an ongoing dynamic process, recovery. And it's working on 4 things, as defined by SAMHSA. Working on your health, both your physical and your mental health. Working on your home, which is not the place you live necessarily. It's a place where you want to be, where you feel safe. And working on the relationships you have with the people there and the home itself. It's your community, because of course, despite what the American myth says, that we are rugged, independent individuals, we have millions of years of evolution. That's like the only reason we survived is because we had community, and so we need community. And then the 4th is your purpose. What is your purpose? What are you on this planet for? What do you want to do with your life? And if you're working on all those 4, that's recovery. And if you're working on getting high, that's the opposite of it. Now, you'll notice I didn't say anything about the medications. And what the medications do is they can take this monster off your back and give you some breathing room so you can actually work on your recovery. Now, some people get on the medications and it works. They decrease their drug use. They get back to functioning at some level, but they're not really in recovery. And maybe that's the best they'll ever do, but at least they're not overdosing and they're not dying, certainly not at the same rates. And if they stop the medicine, that monster comes right back and they go right back to it. Other people get a lot of what they call recovery capital. That could be structure in your life. It could be people in your life that are supporting you. It could be relationships. There's a lot of recovery capital that you can build up that'll help protect you to it. And of course, COVID just took the legs out from so much recovery capital. So a lot of people overdosed. I mentioned there are 4 waves of this current crisis, and the first is prescription drugs. Now, what that did is addict an entire generation of people, vulnerable people, and many of them, kept going back to their doctor, and then finally the doctor would shut them off. Then they started buying pills, and then finally that got too expensive, and somebody says, hey, if you buy some heroin, it's a lot cheaper, and and it works just as well or even better. So they start buying heroin. It comes as a powder on this coast, and they start sniffing it, and then pretty soon they're paying just as much as they were for the pills because their tolerance has gone up. They're using more. So then they transition over to injecting heroin, and then the risks go up, but also the dangers, the amount that you need goes up, your tolerance goes up. So then you're in a lot of trouble. So with all of these people addicted from prescription opioids and then transitioning over to heroin, the heroin supply got tapped out. Now heroin is derived from poppy seed that has to be grown somewhere. And it turns out that fentanyl is synthetic. And if you wanted to take a cooler of heroin and smuggle it into the state of Rhode Island, you might put it in the trunk of your car or somewhere. A comparable amount of fentanyl could fit in a cigarette pack. And you don't need to grow any poppy anywhere. You just need a half decent chemist and some precursors, and you're off to the races. So it was economics that drove it very quickly. Fentanyl comes on a lot stronger and then goes off a lot stronger, a lot quicker. So people have to inject multiple times throughout the day, or smoke, or snort. And it wasn't just fentanyl; it was fentanyl-related compounds. So carfentanil is 1,000 times more powerful than fentanyl. It's an elephant tranquilizer. Now we're in a new era where there's polysubstance use. It's not just opioids. It's opioids, it's stimulants, it's methamphetamine, cocaine, and other things, and alcohol. And of course, as this initial prescription opioid crisis was predominantly Caucasian people, because the doctors were prescribing it, and doctors are predominantly white. And a person of color comes to them, and they have this bias. It's, oh, well, that's somebody who's, drug seeking and it doesn't experience pain like white people, like me. And then, so the doctors were sort of more sympathetic to the pain of the white people. And they just prescribed at much higher rates, which was unfortunately only protective to people of color for a period of time, because as the epidemic evolved into illicit market, it diffused towards people who are more marginalized and more marginalized. So unfortunately, what we've seen in recent years is a dramatic upsurge in overdose deaths among people of color, both Hispanic and African Americans. There's another critical part of the equation here that we haven't spent nearly enough attention to, and that is what is in the illicit market. Several years ago, Ohio had a terrible overdose crisis. And they said, oh, well, we've got to do all kinds of things. And so they set up programs and they started doing things. But then overdose deaths continued to rise, and they did more things. And then overdose deaths came down for a bit. And they said, oh, they patted themselves on the back, said, we did a great job. We stopped all this, by all of our activities. We stopped this. And then the data came out once you could look what was in the drug supply. And what happened was the illicit market was heroin to fentanyl, and then carfentanil came into the state. And the carfentanil arrival, the widespread area, and then dissipation tracked exactly with all those overdoses. So everything they did nothing. It was all just what was in the supply. So it's clear we need to spend a lot more time looking at the supply. I mean, opioids in general have a fairly wide therapeutic index. That is at the lower level the minimum amount you need to get the effect, and at the upper level, the fatal effect. There's plenty of medications that have a very much narrower therapeutic index. So, but the problem is, if you don't know what you're taking, one day you could take enough to just not feel anything, and the next day you could take enough to kill you. Wonderful work by our Brandon Del Pozo and his and other folks recently demonstrated that when police go in and do a massive raid, they disrupt the dealing network, and so all of a sudden people have to go to their number 2 dealer or number 3 dealer or someone else they don't know, they don't have an ongoing relationship with. And that, if you have a regular dealer and you're doing, there's a vested interest, it's not simply a predatory relationship. And if you disrupt that, what you find is a dramatic increase in overdoses, which is what was documented quite clearly. All right, so the quicker we can understand what's in the illicit drug market and how quickly it evolves and respond to it. One example recently is a medication called xylazine, which is a veterinary large animal tranquilizer, which has the unfortunate effect of not only sedating somebody, but it also can cause massive abscesses that are just necrosis. Philadelphia, which has been hard hit, had a dramatic increase in need for wheelchairs and prosthetics and amputations. So as of 2022, xylazine has been found in 48 states. It's been found in a third of the drug samples in Rhode Island this year. In 2019, xylazine was found in 3% of overdose fatalities, mostly fentanyl-related fatalities. In 2023, 4 years later, 11% fatalities. So this is an unheard of rapid change in the dynamic of it. And xylazine can last, 8 to 72 hours. So whether it's just tagging along or actually contributing to the overdose deaths is not 100% clear, but it's certainly representative of what's going on in the drug market. I would just, in closing, say that, as I mentioned, so many people have been impacted by this that, and really what we need is policies that can decrease the stigma. They've done a great job of that in Portugal. They have just a slightest fraction of the amount of problems that we have. So that's a bit light in that direction. We still need to dramatically ramp up treatment. Naloxone, the antidote for an overdose, we need to have it widely dispersed. And we need to educate our general public about real solutions. So I think I will stop there and entertain any questions. Thank you.
Oh, that's fantastic. Thank you so much. And there are questions have been accumulating in the chat. So here we go. The first one is about Rhode Island's Harm Reduction Center pilot program. And do you think that these centers will help reduce stigma?
That's my hope. I visited harm reduction centers in several different countries. The first one I went to was in Vancouver, had been operating for quite a bunch of time. And I went in there, it's almost like, there's a waiting room up front, people sign in and then they have to wait. And then when you get inside, it's almost like a hair salon with, instead of having their heads, but there's little stations around the periphery of the room. In the center, there's a table with all kinds of supplies, and there's circulating personnel who are helping people to get the supplies. And of course, people bring their own drugs. But they told, and then after they're done, and they sit at this desk with a mirror so that they can see what's behind them. So they're, and after they're done, they go and chill out and get juice and crackers and talk to a social worker. There's actually a drug treatment program upstairs from it, and some people want to go up to treatment at that point. They told me one statistic that there had been 1,000 overdoses in that room, not a very big room, and 0 deaths.
Wow.
And I didn't hear any other statistics. So it's very helpful for the people that are able to get there and use it. And it's the people that use it are people that are not welcome anywhere. And I saw this. I went to the one in Harlem last year, and it's phenomenal. They just surround people with love. They said the first thing they do when somebody comes in is they get them clean. And I don't like the term clean in terms of not using drugs. That's not what they're talking about. These people are filthy. They've been living on the streets. They bring them in the back. They have them take a shower. They give them, sweatpants and sweatshirt and socks and clean underpants, and they wash their clothes in the washing machine there, and they take care of them. And then they come out and they give them food, and if they want to use drugs, they can go use them in there. If they want to smoke them, they can do it in there. And then they come out. And these are people, they go into any public place, they get thrown out right away. And they respond in kind. And then they start thinking about, okay, well, maybe I will try methadone or try buprenorphine or try to get into treatment or get into a program. It's wonderful. For the people that are there, it's wonderful. Now, Rhode Island last year, we had over 400 people dying. We've been struggling for years now to try and get this set up. It may get set up this summer. If we can save 5 lives with that, 10 lives, that would be phenomenal. That would be great. But it's not going to take care of the other 400. So they're wonderful. They're great. They're proven. They've been around in a dozen different countries. There's not been a single overdose fatality in any one of them ever. And the reason is because you're there. It's not like you find someone down on the street or in their apartment or in the car, or whatever. You're there as they're going out. So one of the main interventions is a lot of oxygen. And they don't give someone Narcan right away, because that, of course, will precipitate acute withdrawal. They give Narcan, but they give us, or naloxone, they give a small amount. And then they have they titrate up what they need and oxygen. So they're wonderful. And looking forward to having it here, but it's not the whole answer. It's a small part of it. And decreasing the stigma is a big part of that.
Those are the same as safe injection sites.
So it turns out if you call it a safe injection site or a safe drug consumption site, that's a little less palatable than an overdose prevention site to the general public.
Got it. Another question is related to mental resilience. How much does that affect recovery and preventing relapse? And a secondary question is whether mindfulness could be used in addition to the medications to control the problem.
So the most effective thing we have is medications. And, a lot of people talk about 12-step meetings and, other things. And in fact, even the term used to be MAT, medication assisted treatment.
Right.
And we've tried to get away from that term, because that implies that there's some magical treatment that the medication is assisting. But you can do all the mindfulness, you can do all the other stuff. And if they don't have the medication, none of it's going to work for most people. So the medication is the treatment. But there are, I think a lot of other things can help. And the whole thing about mental resilience, I'm not sure I know what that is, but when people had depression before we understood that actually it's that you can give someone a chemical and they will actually get better, we just blamed it on the patients, their fault. Though they have low mental resilience, and the people that do have mental resilience don't get it. And then it turns out, well, actually it's a disease, and if you give them the right treatment, they do fine. So I don't really buy that.
Another question is related to community education. And are there efforts to educate our communities on the dangers of these drugs and their negative effects?
Yeah, there are. I'm not very involved in it, but communication and education is critical to getting ahead of this. And in particular, we've seen a dramatic increase in stimulant-related deaths. So some of those are people dying with stimulants in their system, cocaine or methamphetamine. But the majority of them are dying with stimulants and fentanyl or a related compound in it. So they're getting an opiate. But when we look at those people that are dying, it turns out they are not people with opioid use disorder. They are people who have use stimulants, but they got a stimulant that was contaminated with fentanyl. Of course, they don't have any tolerance for opioids because they're using stimulants, and they overdose right away. They also don't have any access to, most people with opioid use disorder, they're targeted for education about using naloxone, don't use alone, they have these harm reduction messages and interactions, whereas the people who are just using stimulants don't get targeted those messages. So we are thinking about ways to actively get to those people as well.
And I saw a headline in the New York Times a couple of days ago that there is a call to stop using the word overdose and substitute it to poisoning. In other words, instead of it being a drug overdose, it's a drug poison.
Yeah. I mean, that's on the one hand, that's semantics. On the other hand, if somebody that in that article there was a woman who described her son that he wasn't seeking drugs. He went to a pharmacy in Mexico and he bought a Percocet and he took that and it happened to have fentanyl in it, and so that's why she feels that that's a poison. But again, if you really think about that, why is she so upset about that? Why is she? It's because of our stigma. We stigmatize this. So she doesn't want her son, her dead son, to be one of those people that have addiction to drugs. He was not a drug addict. He just made a bad choice. And that kind of, and I don't begrudge her that, but it sort of diminishes the humanity of everyone else who does have addiction, and so I don't really care what you call it or not. I mean, we definitely need to track it. And there have been problems tracking it, small counties and small places, rural places, a young person dies. The county coroner is often not a physician, not even, it's like they don't have any training, and the family knows them. They buy them, they use cars from them, and they say, oh, don't write on the death certificate he had an overdose of drugs. No, just write he had a heart attack, because we don't want that stigma. It's stigma for the child, but it's also stigma for the parents. Like, oh, you're the parent, it's your fault because you're a bad parent. So and of course, our main response to this whole problem, and in terms of how much we're paying for it continues, is through the criminal legal system. And the DEA is, they're cops, and they are an enforcement agency. And they have rounded up these parent groups to try and promote that, because it works into their narrative of, there's, if somebody's poisoned, then there's somebody doing the poisoning, and that's the bad guy, and we got to get that guy, and that's how we're going to solve this problem. Well, they've had 50 years, 40 years to do that, and it's been an abysmal failure. We've filled up our prisons, we've disrupted a lot of lives, and the Europeans think we're absolutely crazy. They say, don't you know that punishment doesn't work with addiction? That people need treatment. So that's what we need.
Well, this has been a spectacular experience. Thank you so much. And we've all learned a lot, and I especially appreciate your reverence for the humanity of the folks that you're working with.
Yeah.
And that's really great. So, we will be having another seminar in a month, and we'll have two of our talented advanced CTR awardees speaking. And the slide is on the screen there, and these are recorded if you have colleagues who are not able to join us today. And there will be, we do ask attendees to please provide us with an evaluation. And Jody, thank you again so very, very much. Really,
Thank you. If you could send me the chat, I'll try and email the people with their questions.
I'll let my technical assistants take care of that. And lots of really positive comments also in the chat, not surprisingly. So again, thank you, everybody, and
Thank you.
see you next month.